Hi, Anshul.
हाय अमित बॉस आ गए क्या?
Yes, yeah, dear.
ओह,
So we are now live.
Great.
We can start now.
Sure. So, hello, good evening to everyone, and welcome for this very interesting webinar on the management of chronic myeloid leukemia. To have our speaker, we have a very eminent speaker, Dr. Anshul Agrawal from Varanasi. So, Dr. Anshul Agrawal is a DM Medical Oncology from Tata Memorial Hospital, a prestigious institution. Dr. Anshul is working presently in Homi Bhabha Cancer Hospital and MMCC Varanasi as a senior specialist. And Dr. Anshul has got a lot of credit to him for some research work as well. I think it's important to understand in the today's scenario about the chronic myeloid leukemia, and I'm sure Dr. Anshul is going to talk about the road ahead for imatinib treated patients to us today, and he will also discuss one or two case studies as well in the later half. So, without any much ado, we welcome Dr. Anshul Agrawal here, and over to you, sir, for your presentation. So you have 30 minutes to deliver your talk on road ahead for imatinib treated patients. Over to you, sir. Dr. Anshul, please.
thanks for the warm welcome. So, as for the introduction, I am going to start regarding awareness of the CML. So, road ahead for imatinib treated patients. As we know that now the CML survival is now approaching to similar to the general population, age or gender matched general population. This was happened because in development of the magic bullet in 2001, imatinib was discovered. Imatinib was FDA approved in May 2001, and because of that, this TKI, the scenario is totally changed in the treatment of CML. So, German CML study group, which shows that the primary has maximum survival as compared with interferon or urea boost, which were used at that time. So the first study which was done with imatinib was IRIS study. So IRIS study, there are two arms in which one arm there is imatinib, the other is interferon alpha plus RRC. So there was a huge crossover between the arms. The crossover was because of the lack of response, because of the loss of response, and because of the intolerance of treatment. So if you see that we at the 10-year data we got survival 80% in 10 years, and also in interferon alpha plus cytarabine we received the survival of 78.8%. So this survival which we got in interferon alpha plus cytarabine, it is because of the crossover to imatinib. Near about 65% of patients did cross over to imatinib arm in median duration of 0.8 years of interferon alpha plus cytarabine. So after this IRIS study, so there was another study, the CML study 4, in which the imatinib was combined with various other therapies, like imatinib was combined with interferon, imatinib dose was increased to 800 mg, imatinib was combined to cytarabine in an arm, and imatinib was used after interferon failure. So in all these studies, we got nearly an overall survival of 82% and PFS of 80%. And all these survival is the molecular milestone at 3, 6, and 12 months. So patients who reach the molecular milestone at 3, 6, and 12 months have a significantly better survival. So we did get a faster response with the imatinib 800, but this faster response did not translate into the survival advantage. So survival in CML it's the one objective with multiple variables. So The predictors of prolonged survival in CML are faster and deeper molecular response, prevent progression to APBC during TKI therapy, prevention of development of resistant mutations, and management of TKI-related toxicity. So, when the IRIS study, follow-up of the IRIS study was done, it was seen that 45% of the patients continued frontline imatinib. And this discontinuation is because of the adverse event in 35% of the patient, unsatisfactory therapeutic effect also, and due to the death and stem cell transplant. And maximum number of progressions were in the first 3 years. Either it will be a loss of CHR, loss of major cytogenetic remission, AP, BC, or death during treatment. All are maximum in first 3 years. So after progression to APBC, in both IRIS trial, in both NSND trial, the median survival is reduced. In median survival in IRIS trial is near about 10.5 months after progression to APBC. And post-imatinib failure, if we see by phase, in chronic phase, survival is 72% at 3 years. In accelerated phase, it is 30% at 3 years, and in blast phase, it is 7% at 3 years. So there are some debatable questions. Should we wait till progression before switch, or can we predict early treatment failure? What is the time to switch? It's 3 months, 6 months, 1 year, or 2 years? And should we consider switch depending on treatment goals and risk status? So if we know these milestones, for optimal response, if patient achieve BCR-ABL percentage 10 or less than 10 at 3 months, 1 or less than 1, and 0.1 or less than 0.1 at 12 months, this is the optimal response. In these cases, we have to continue the same therapy. In case of failure, like a patient did not achieve a BCR-ABL of BCR-ABL 1 of 1% at 6 months or 0.1% at 12 months, so it is a ELN failure. And in between this is warning. So in case of failure, we have to change the therapy. And ELN recommends that before changing the therapy, we have to do a repeat test. So if we see that the early molecular response at 3 months with imatinib, if the patient who failed to achieve the early molecular response at 3 months with imatinib, so if we followed that patient for next 3 months, only 13% of the patients with EMR failure at 3 months achieve an optimal response at 6 months. That's 87% of the patients fail to achieve the optimal response at 6 months. So this is the ELN 2020 guideline in which cytogenetic criteria was removed from monitoring the response. And if we see that the optimal response is at 3 months, BCR-ABL should be less than 10%, at 6 months, less than 1%, and in 12 months, it is less than 0.1%. Comes if it's ELN 2020 recommends earlier switch at 3, 6, or 12 months. Also, if we see the NCCN guideline also, it recommends the earlier switch to alternate TKI in case of suboptimal responses. ESMO 2017 guideline, it incorporated the MR4 as optimal response milestone. As you see, MR4 is more in it should be achieved near in 18 months or more than 18 months. So now we come towards nilotinib. As we know that nilotinib binds 35 to 100 times more faster than imatinib and is more effective than imatinib. So in CML patients who are in chronic phase, who are imatinib intolerant or imatinib resistant, we have used nilotinib. So this study was a 48-month follow-up of a phase 2 study. So at 48 months, if we see that the patient who achieved baseline CHR have a good survival as compared with the patients who did not achieve baseline CHR. Also, the overall survival rate, estimated rate of overall survival at 48 months was 78%, and median survival is not yet reached. So most frequent drug-related non-hematological adverse events occurring in more than equal to 10% of the patients. So if we see 3 and 4 adverse events, the percentage of adverse event is very less. And the important thing is that this is a 48-month study. So these adverse events are mostly pronounced in first 24 months. Next 24 months, the rate of adverse event was very low. Like these hematological adverse events, these are also more pronounced in first 24 months, and additional events between 24 and 48 months are very less. So to conclude that with a minimum follow-up of 48 months, nilotinib continued to be effective in patients with CML-CP with imatinib resistant or intolerance. No new safety signals was observed, and few additional events have occurred in patients remaining on treatment since the 24 months of follow-up. Deeper molecular responses at 3 and 6 months were significantly correlated with PFS and OS at 48 months. Now, previously we have used nilotinib in the CML-CP. Now we have used nilotinib in accelerated phase patients who are imatinib resistant or intolerant. So at 24 months, only 70% patients were alive. The median overall survival has not been reached. Non-laboratory adverse events are very less. If pathological adverse events were there, thrombocytopenia, neutropenia, anemia was there. So to conclude that with 24 months of follow-up data, nilotinib continued to be effective with durable hematological and cytogenetic responses in patients with imatinib or intolerant CML-AP phase. So CHR is achieved in 58% of the patient, major cytogenetic response in 32% of the patient, cytogenetic response in 1%, and OS in 70% of the patients. Now we see about the cross intolerance with the nilotinib. So there is very in not toxicities, there is very less cross intolerance. In hematological toxicities, also there is less cross intolerance. So intolerance was enabled in CML-CP and CML-AP who were treated with nilotinib. Thrombocytopenia was the only imatinib-related adverse event that lead to nilotinib intolerance in some of the patients. And nilotinib is an excellent therapeutic option for patients with prior intolerance to imatinib. This is CMR. So in this case, the eligibility criteria of this trial is patients should be in CML-CP with a greater than 2 years of and had a complete cytogenetic response and no MR 4.5 at screening. So some patients are randomized to nilotinib arm. They were changed to nilotinib 400 mg BD, and some are continued at the same dose of imatinib. So after 24 months of this study, patient who didn't achieve this MR 4.5 in the imatinib arm was changed to nilotinib, switched over to nilotinib. So if we can see, by 12 months of this study, the number of patients who are achieving MR 4.5 is more in the nilotinib group as compared with the imatinib group. By 24 months, it's also more in the nilotinib group as compared to the imatinib group. And after this, we have crossed over the patients to nilotinib. So we can see that it's near 21%, it's 26, 28. So there was no major improvement in the imatinib. But after crossover to nilotinib, we see a good percentage of improvement in MR 4.5. So in patients with residual disease after more than close to 2 years on imatinib, switching to nilotinib 400 mg BD resulted in higher rates of MR 4.5 than remaining on imatinib. So the goal of CML therapy is moving from previously it was disease control to get the best overall survival. Now is operational cure to get the treatment-free remission. Thank you. Is there any questions? Hello?
Yeah, hi, Anshul. So you have only discussed with the cases of imatinib, which started post-failure, nilotinib started post-failure of imatinib. To take on the patient to start upfront on nilotinib? When considering patient to start upfront on nilotinib?
Hello?
Yeah, Anshul, audible? Dr. Anshul, are you audible?
So, yeah, audible. So the thing is that, you are audible. The thing is that the NSND trial, so we could get a good deep molecular response. We could get a less number of patients which move to AP and BC in the nilotinib arm. But if we see the overall survival in the trial, NSND, or the trial of Decision also, the overall survival was equivalent, or there was no change in the overall survival. So we can use upfront nilotinib if we want to achieve a treatment-free remission, early treatment-free remission. So there are some scenarios in which we can use nilotinib early.
Yeah, true. Basically, in in the clinical practice, we are those patients in which we are trying to have an early and deep molecular response so that they can stop their therapy in the near future, like pregnant patients,
like a pregnant patient
or young male patients. We may consider to start nilotinib or dasatinib based on their comorbidity profile or any previous disease history they are having. True.
Yeah, completely agree.
Yeah.
Yeah.
Dr. Yashwant, are you there?
Yes. Anshul, what is the workup which we need to do before starting nilotinib, which we should do?
So as we know that the major side effect of nilotinib is a cardiac side effect. So we have to do an ECG, we have to do a 2D echo, and we have to create a good history if there is any prior history of any peripheral vascular disease in the patient. So we have to screen for that blood sugar level because it causes hyperglycemia also. We have to level the lipase level at the baseline because it causes the pancreatitis in some patients. So majority is the cardiac complications. So we have to look for the ECG, echo, lipid profile.
Okay, Dr. Anshul, this is Dr. Akhil. Do you think we should do tyrosine kinase domain resistance mutation testing in all patients in ALL upfront? What is your practice? I mean to ask for selecting nilotinib, dasatinib, or imatinib, do you do testing in ALL patients who are Philadelphia positive to select the therapy, or you like to start with imatinib or nilotinib or dasatinib?
We can start with imatinib and dasatinib. We are not doing any testing at baseline for the tyrosine kinase domain mutation analysis.
Okay. Thank you.
Let me move towards the case scenario. So this is a case-based discussion. Should I start? Are you able to hear me? Should I start?
Yeah, we are able to hear.
So this is a 40-year-old gentleman present with weakness and fatigability since last 3 months. If you see the hemoglobin, it was 13.4, WBC was 2,20,000, platelet was 3,50,000, spleen was 15 centimeter, and blast in peripheral blood was 5%. So the bone marrow was hypercellular, and RT-PCR for BCR-ABL was 80%. It was Sokal risk score intermediate, and patient had a history of asthma which was controlled on inhaler. So what is your choice of first line therapy? Is it imatinib, dasatinib, nilotinib, bosutinib? So what would be your choice? So would a history of lung disorder or infection impact your decision making? Would high risk score have impact on the choice of first line therapy? So this patient, we started with imatinib 400 mg per day. So we achieved CHR by 2 months. RQ-PCR of BCR-ABL was 22% at 3 months. Patient was totally compliant on therapy and have some intermittent GI disturbances. So I'm asking a question: what are the long-term chances of achieving optimal response of PFS of this gentleman? So Akhil, these are high or low? Akhil, are you able to hear me?
Yeah.
So what are the long-term chances of achieving optimal response and PFS of this gentleman?
So it seems
we had BCR-ABL at 3 months is 22%.
Yeah.
What is your opinion?
Even with and the patients, if we start nilotinib or dasatinib, chances are somewhat higher, around 5 to 8% higher. We don't have data for oral survival benefit with long-term use of TKI, second generation or third generation, but it seems that the patients who in which we want to achieve TFR, and we want in female patients where we want pregnancies, so we need to discontinue. In those patients, we can select definitely second or third generation TKI. That's my take.
Okay. So in this patient, we have started in imatinib and we achieve a CHR by 2 months, but BCR-ABL was at 3 months was 22%. So this was reported in JCO that BCR-ABL translate level at 3 months is the only requirement for predicting outcome for patients with CML treated with tyrosine kinase inhibitor. So patients with translate level of more than 10% at 3 months have significantly lower 8-year probabilities of OS, PFS, cumulative incidence of CCR, CMR than those with higher translate levels. And also in this article which was published in Leukemia, the persistence of more than 10% BCR-ABL at 3 months separated a high-risk group from a group in which BCR-ABL level was between 1 to 10% from a group in which BCR-ABL level was less than 1%. So repeat RQ-PCR for this patient was done and BCR-ABL at 4 months was 20%. So what will be your therapeutic strategy? Dr. Amit, what will be your therapeutic strategy? Hello? Are you able to hear me? So in this patient, we achieved CHR at 2 months. Then RQ-PCR, BCR-ABL at 3 months was 22%. Again, after 1 month, we repeated RQ-PCR, BCR-ABL at 4 months, which is 20%. So should we maintain imatinib at current dose or increase imatinib dose at 600 to 800 mg or switch to a second generation TKI?
Yeah, we have to sense the IRMA profile of the patient to rule out what is the mutation present for this patient. And for the time being, you can, waiting the result, you can increase imatinib to 600 or 800 mg for the patient. And then depending on the IRMA profile, then change to second generation TKI for this patient. Okay.
Okay.
Completely agree with the comment by Dr. Amit.
Okay. So if you see the ELN 2020 guidelines, so if we didn't achieve the required optimal responses, pardon?
Yeah, go ahead.
If we did not achieve the required optimal responses at 3 months, 6 months, or 12 months, if it comes in failure category, we have to change. We have to earlier switch. We have to change the TKI. Also in NCCN guideline. So as my Dr. Amit said, we have to increase the dose to 600 mg. So, but patient starting having complaint of diarrhea and GI disturbances, and BCR ABL at 6 months was 18%. So, what will be your next intervention? So, Dr. Yashwant, what will be your next intervention? Will you repeat RQ-PCR at 9 months?
I think Yashwant
Advice
is
for
not,
TKD mutation testing? Okay.
I think Yashwant
So,
is
Dr.
not there.
Ahmad,
Ask to Satvik or Dr. Amit Agarwal
so,
or Sunil are there.
Dr. Satvik, what will you do? So, what will be your next intervention?
I think so. Satvik is.
Okay. So BCR-ABL at 6 months is 18%. So we have advised for a TKD mutation testing, and we got a mutation which was F317L. So in light of this mutation and history of asthma, nilotinib was started. So if the mutation comes negative, what will be your therapeutic strategy, Dr. Akhil? If this mutation came negative,
Yeah, if mutation
and
comes
patient's
negative,
BCR-ABL at 6 months is 18%.
if mutation is negative, then it is a difficult situation. Definitely, as Dr. Amit pointed out, that we can increase the dose. If it is being not tolerated, then it is a difficult situation. We can definitely try for nilotinib or dasatinib. We can, without any mutation also,
so we have increased
because, yeah, we can try starting second or third line generation TKIs like dasatinib or nilotinib, whatever is feasible, and we can counsel the patient for allogenic transplant.
Yeah, we have to switch over.
Agreed with
Not
Dr. Akhil.
imatinib, better to switch to the second generation, either dasatinib or nilotinib, based upon his comorbidity profile. That will be the best option for the patient.
Okay.
Sunil is also
Yes,
there.
change to second or third generation and then wait.
Dr. Sunil, what is your opinion?
I would like to consider increasing the dose initially, and if still.
So, but we have increased the dose to 600 mg, na?
We can increase it.
We have increased the dose to 600 mg, and patient is having diarrhea, GI disturbances,
then
and 6 months we have BCR-ABL of 18%.
Consider change to second line or third line TKI. Nilotinib,
Okay.
told by Dr. Amit.
Okay.
So, doctor.
So, treatment recommendation based on
Patient could not
BCR-ABL.
tolerate 600 mg dose, and the patient is and BCR-ABL is high. So that is why I think changing to Nilo or DASA would be a good choice in the absence of tyrosine kinase domain mutation, and wait for some time, 3 months, and then repeat the testing. If the patient is still not getting any benefit, BCR-ABL is rising, then we need to counsel for allogenic stem cell transplant. And Dr. Amit, do you think this is the correct statement?
Yeah, it's true, but we have to wait for the response after second generation TKI.
Yes, I completely agree. That response after 3 months, and if at least if it remains stable, we can try for 3 more months. But if it is rising, then we need to do something and counsel for transplant. Dr. Amit, in your practice, Dr. Anshul and Dr. Amit, in your practice, what do you think? How many times you get the tyrosine kinase domain mutations in IRMA testing? Because in my practice, I think IRMA is at least 50 to 60% time negative. What is your take on this?
Yeah, something like that. Only in around half of the times we'll get a mutation, in half times we don't get any mutation in the IRMA testing. It's true.
Yeah.
Okay.
I agree with.
Yeah.
Yeah, I agree. I agree with Dr. Amit and you.
Yeah. Okay. Yashwant or Sunil, any comment?
Agree with Dr. Akhil, what Dr. said.
Okay. And Dr. Anshul, please go ahead.
So, if you see the NCCN guidelines, these are some mutations which, in this patient, we have F317. We cannot give bosutinib, dasatinib. We have to give the nilotinib. So, there are some other mutations in which a different TKI can be given. So, we have to see the mutational profile before changing a TKI. So, in this patient, nilotinib was started, nilotinib 400 mg BD was continued, and at 6 months we achieve a BCR 1%. And if we see at 24 months, we achieve MR 4.5, and after that, this MR 4.5 was achieved, maintained for 1 year. So the total TK duration of this patient was 3.5 years, and in which we achieved MR 4.5 and maintained it for near 1 year. So is it reasonable to proceed to TK suggestion under close monitoring?
Please
So
repeat.
should we? So in this patient, the total duration of therapy was 3.5 years. Of TKI therapy was 3.5 years. Initially, we have given imatinib. After that, we have changed to nilotinib. And after nilotinib, we are getting stable MR 4.5 for which was maintained for 1 year. So should we stop
No.
the TKI and do a close monitoring?
No, not at all. If a patient has progressed on any previous lines of TKI, he is not a candidate for further stoppage of therapy. So this patient has to be continued throughout his life, nilotinib. So
this patient has required second line therapy, so we should not consider for TFR for such patients.
I agree with the comments by Dr.
So if you see this trial, NS-STOP trial, it's a single arm phase 2 study in which adults with CML CP patients who are having more than 3 years of TKI therapy, first with the imatinib and then after nilotinib, which nilotinib was taken for more than or equals to 2 years. There was no documented MR 4.5 at the time of switch to nilotinib and achieve MR 4.5 on nilotinib. So in this, the patient were enrolled and nilotinib consolidation phase was given, and if there is no loss, no confirmed loss of MR 4.5, so it was stopped. And if there is confirmed loss of MR 4.5, it was continued for next 52 weeks. If we get MR 4.5 again, then we continue the TFR phase. So if we had a loss of MMR or confirmed loss of MR4, so nilotinib DT was initiated. So in this trial, it was done, and the result of this trial, so at 3.7 years, the treatment-free remission rate was 46%, which is a very good rate at 3.7 years, if we can see. So, Dr. Akhil, what? Akhil and Amit.
Yeah, basically it's
the result of one trial. I will not convinced.
This trial,
I will like to continue. Yeah.
The present
Dr.
guidelines.
Amit or Dr. Yashwant, what is your take? Yeah.
Yeah, the present guidelines only suggest to continue TKI if the person had progressed on a previous line and have a TKI resistance to any of them. So
according to the trial, if you see, we have stopped the TKI, and up till 3.7 years, the treatment period remission rate was 46%.
Basically, this trial gives us a hope that in selected patients who are very keen on stopping the therapy and are ready to take the chance, we have got some evidence for that, but still it's not for a regular routine practice. It is based on patient-to-patient basis.
Completely agree, Dr. Amit. This should not be a routine practice, and we should counsel against this to the patients, because with a single trial, we should not. We have still limited data for TFR, and especially in this situation when the patient has progressed on first one generation of TKI and then we needed second or third generation TKI. Completely agree.
Okay. So, I end my discussion.
Okay, it's a good discussion, Dr. Anshul. It's a really a good case.
Thank you. Thank you.
Okay.
Thanks for the real discussion of the patient. It is really very helpful for planning the treatments and discussing the nuances. Yes.
Anshul sir.
Thanks to all.
Hi sir. Sir, for the benefit of group, can you share the slides for the case presentation, because we can't see the slides, sir. For the rest of the.
You are not able to see the slides.
Yeah, sir.
Okay. Just wait.
So basically, even if we don't see the slides, the discussion was purely important, and the discussion could go on. That was important. So I
Yeah,
think, yeah.
it's a good presentation, sir.
You are not able to see the slides. I was not aware.
That's okay. No issues with that.
Okay, okay,
Yeah, no issues, no issues. We had good discussion. Yeah.
okay, okay. Thank you.
Tarun sir, if
Thank
any question in the chat box, can we go for it?
So
So
I
in
think
the
in the
chat
most of
box,
the questions of chat box have already discussed, A. Anybody has any comment on 3315A? Dr. Amit or Dr. Anshu?
is it T3155 or? Yeah.
Basically, there is a chart regarding the mutations, different mutations. One is getting on the IRMA mutation to analysis, and based on that and the sensitivity of different TKIs has to be checked. So exactly about T315A, I'm not aware. I have to see that and to plan treatment accordingly on that.
Yeah. So I'm not sure it's T315A
So there's one.
because it
There are
is
some
not a
methods.
common mutation.
So there are some questions. Question one from Sunil, that what is your take on considering CML as chronic illness as hypertension? Yeah, this is a good question. Are you able to hear me?
Yes,
So
yes.
this is a good question because now if we see that CML gets the survival of CML is approaching near to the general population. So now because of the comorbidities and other illness, we are getting the events because of the comorbidities and other illnesses also. So we can think it as a chronic illness like diabetes, ICD, hypertension.
Yes, agree. Because when we see the graphs of survival with the non with that of normal population, that is important thing.
Okay. So the question is from one Shruti Meenakshi to everyone is that T3155. In T3155 mutation, we go for a ponatinib, omisataxin, or we can use transplant in T3155 mutation.
We have some data for hcmpl as well, I think, which is active in T315I as well.
Yes.
Dr. Amit, is hcmpl
Yes,
active
yes.
on T315I?
Yeah, it has got, I think so, it has a role in that. Decide omacytaxin are another options, but still in clinical practice, we still are going for transplant for all these patients of T315I mutation at present.
Yes, yes. We try to get compassionate access of either ponatinib or hcmpl, and if we feel that it is not possible, we definitely counsel for allogenic stem cell transplant, preferably sibling transplant if match is available.
Yes. Okay. So
Yeah. Great discussion,
I will
Dr.
end my
Anshul.
discussion.
Yeah, yeah. Thank you, Dr.
Thanks
Anshul,
for
Dr. Amit, for the
participating.
great discussion, and Dr. Sunil and Yashwant as well.
Okay. Thank you.
Hi, sir.
Okay.
Thank you, sir. Thank you so much for such a wonderful lecture, and hope everybody get the benefit for using the second generation TKI, sir, where the imatinib or first generation TKI is not good. It's a wonderful presentation, sir. Thank you so much, sir, for giving your time, and thank you, audience.
Okay.
Have a great weekend.
Yes.
Thank you. Thank you, Dr. Anshul. It's a great show. Thank you. So can we leave now? Can we leave the meeting, Vinod?
Thank you.
Yeah.
Yes.
Yes.
Okay. Okay. Thank you. Thank you, support team. Thank you, Aru. Thank you, everyone. Thanks.